Generalities of hemoglobin. Hemoglobin is constituted by the union of iron, protoporphyrin, and globin. Iron comes from nutritional intake, protoporphyrin comes from the succinyl-CoA cycle, and globin comes from protein synthesis. Storage process of iron and formation of hemoglobin. Iron comes from nutrition. When we ingest iron, the intestine has a transporter that decides how much iron will be absorbed. This transporter is synthesized by the HFEC282Y gene. In cases where this transporter is altered, primary hemochromatosis is expressed. Under normal physiological conditions, this transporter, HFEC-282Y, regulates the amount of iron to be absorbed. When absorbed, this iron begins to be deposited in the form of storage, creating ferritin. Ferritin has an inversely proportional relationship with TIBC. If ferritin decreases, TIBC increases. If ferritin increases, TIBC decreases. Hepcidin plays a very important role in these processes, because it is in charge of regulating how much iron stored in the form of ferritin goes out to the periphery. Protoporphyrin comes from succinyl-CoA. This succinyl-CoA is transformed to aminolevulinic acid through aminolevulinic acid synthetase. This enzyme requires vitamin B6 as a cofactor. Aminolevulinic acid is converted to porphyrin B through aminolevulinic acid dehydrogenase, and subsequently porphyrin B is transformed into protoporphyrin. Protoporphyrin needs to enter the mitochondria of the macrophage through ferrochelatase to take up the stored iron and form the HEM group, which later binds to globin to form hemoglobin. Destruction of hemoglobin. Within the hematological physiological mechanisms, the programmed destruction of hemoglobin is present. When hemoglobin completes its life cycle, it is broken down into iron, globin, and protoporphyrin. Protoporphyrin is taken up by blood macrophages, which break it down into unconjugated bilirubin. Unconjugated bilirubin is insoluble in water but soluble in lipids and has the ability to cross the blood-brain barrier. Because it is insoluble in water, it requires a transporter to be able to be mobilized in the intravascular space, which is why it is captured by albumin, which is responsible for transporting it to the liver. Once unconjugated bilirubin is in the liver, it is converted to conjugated bilirubin by UDP-glucuronil/transferase. Conjugated bilirubin is soluble in water and insoluble in lipids, therefore it does not have the ability to cross the blood-brain barrier. The conjugated bilirubin is secreted to the intestine, where it interacts with the normal bacterial flora. This bacterial flora transforms the conjugated bilirubin into urobilinogen. 80% of urobilinogen is secreted in feces, 10% in urine, and 10% is reabsorbed. Anemias are classified as microcytic, macrocytic, and normocytic. And depending on the respiratory index, we can determine if they are low production anemias or high destruction anemias. Classification of anemia. Microcytic anemias, the mean corpuscular volume is below 80. All microcytic anemias are classified as low production anemias, therefore, the respiratory index in microcytic anemias is below 2%. Within the microcytic anemias we find microcytic anemia due to iron deficiency, microcytic anemia due to chronic diseases, thalassemia, and sideroblastic anemias. Normocytic anemia. Normocytic anemia may occur due to excessive destruction of hemoglobin or due to low production of it. In the case of having normocytic anemia due to increased destruction, the respiratory index would be above 2%. In case of normocytic anemia due to low production, we would find the respiratory index below 2%. In general, normocytic anemias have a normal mean corpuscular volumen, 80 to 100. Macrocytic anemia. This type of anemia can present due to a defect in the production of nucleic acids with megaloblastic or non-megaloblastic characteristics. Macrocytic anemias presents mean corpuscular volume above 100 and respiratory index below 2%. Macrocytic anemias with megaloblastic characteristics are vitamin B12 or cyanocobalamin deficiency and vitamin B9/folate or folic acid deficiency. Macrocytic anemias with non-megaloblastic characteristics are secondary to cirrhosis, ethanol, medications, and metabolic diseases. 3. Microcytic anemia. Microcytic anemia due to iron deficiency. Usually secondary to malnutrition. It presents with low serum iron, low ferritin, high free protoporphyrin, and high TIBC. It can occur in the context of a patient with colon cancer or in the context of metrorrhagia or malnutrition, or in general any slow bleeding can also be associated with this type of anemia. Sideroblastic anemia. It can be caused by various situations. First, X-linked genetic defect in which there is deficiency of the enzyme aminolevulinic acid synthetase. Second, due to vitamin B6 deficiency. Third, due to lead poisoning. In sideroblastic anemia due to a genetic defect linked tox, aminolevulinic acid synthetase deficiency, since the enzyme is not present, succinyl-CoA cannot be converted to aminolevulinic acid, generating deficiency in levels of protoporphyrin and avoiding the formation of the HEM group. In sideroblastic anemia associated with vitamin B6 deficiency, vitamin B6 functions as an activation cofactor for the synthetase enzyme, so when it is deficient, it would prevent the transformation of succinyl-CoA to aminolevulinic acid, generating protoporphyrin deficiency, which would lead to an absence in the formation of the HEM group. In sideroblastic anemia associated with lead poisoning, we can see a blockage of the function of the enzyme aminolevulinic acid dehydrogenase and ferrochelatase, blocking the metabolic pathway for the formation of protoporphyrin and at the same time preventing protoporphyrin from achieving iron extraction from macrophage mitochondria. Microcytic anemia secondary to chronic diseases. Chronic diseases cause chronic inflammation. In this case, the body assumes the chronic inflammation as a bacterial infectious process, therefore, hepcidin is activated and prevents the release of iron stored in the form of ferritin towards the periphery, generating a decrease in the amounts of serum iron, but increasing the amounts of iron in the form of storage, ferritin. In microcytic anemias secondary to chronic diseases, we will find low serum iron levels, high ferritin, low TIBC, and high free protoporphyrin. 4. Macrocytic anemia. Megaloblastic macrocytic anemia. The mean corpuscular volume is above 100 and is associated with a deficiency of vitamin B12 and vitamin B9, which are responsible for the conversion of homocysteine to methionine. In B9 deficiency, methylmalonic acid levels are normal. It is associated with a low intake of vegetables. We can find deficiency of this vitamin during pregnancy and in states of alcoholism. Frequently associated with patients who have diets based on tea and toast. Treatments are based on replacement of 1 mg orally/day of folates. In vitamin B12 deficiency anemia, methylmalonic acid levels are high. It is associated with low meat intake, which is why it is highly associated in strict vegan patients. It can present as pernicious anemia in the context of antibodies attacking parietal cells, Crohn's disease, or in gastric bypass surgery. This vitamin, B12, is stored for a period of 3 to 10 years. Its deficiency can generate neurological symptoms due to destruction of the dorsal columns and lateral cords. Vitamin B12 deficiencies can be evaluated with the Schilling test to determine if the problem is nutritional or absorptive. 1. Administration of vitamin B12 with injection to saturate liver receptors. 2. Oral administration of vitamin B12. 3. Measurement of urinary vitamin B12 levels. If we find high or positive levels of vitamin B12 at the urinary level, we will determine that the problem is nutritional. If the levels of vitamin B12 in urine are negative or low, we will determine that the problem is absorptive. 5. Normocytic anemia. Sickle cell anemia. It presents with cycled cells, secondary to abnormal exchange between glutamic acid and valine in the beta-globin chain, due to an alteration in chromosome 11. In states of acidosis, hypoxemia and dehydration, vaso-occlusive crises can be evidenced, which generates myocardial and cerebral infarctions, acute chest/acute brain. Diagnosis can be made by peripheral blood smear or hemoglobin electrophoresis. Treatment is focused on trying to raise fetal hemoglobin levels with hydroxyurea. In a state of crisis, intravenous fluids, oxygen, transfusions, trying to avoid the risks of secondary hemochromatosis with deferoxamine, and pain management are administered. Glucose 6-phosphate deficiency. Under normal physiological conditions, glucose 6-phosphate protects erythrocytes against oxidative stress, therefore, its deficiency makes erythrocytes vulnerable to oxidative stress. There are drugs that increase oxidative stress such as dapsone, trimethoprim/sulfa, and nitrofurantoin. In addition, there are foods that can increase oxidative stress, such as faba beans. There are two variants of glucose 6-phosphate deficiency, the African variant and the Greek variant. Black patients are more affected by exposure to dapsone, trimethoprim/sulfa, and nitrofurantoin. In contrast, patients of Greek heritage are more affected by exposure to fava beans. The diagnosis can be made by blood smear, where Bite cells and Heinz bodies are found. The treatment is focused on giving support. Spherocytosis. It occurs secondary to problems in membrane proteins, such as spectrin, ankyrin, and pallidin. The anemia is generated due to the spleen marking the erythrocytes with spherical shape so that they are destroyed. The diagnosis can be made through blood smear, where the spherical shapes of the red blood cells are observed, or with the osmotic fragility test. Autoimmune hemolytic anemia. Presence of spherocytes with positive CUMs. CUMs can be positive for immunoglobulin type M or immunoglobulin type G. The presence of CUMs positivity with immunoglobulin type M indicates cold antibodies, the presence of immunoglobulin G indicates warm antibodies. Autoimmune hemolytic anemia with positive CUMs for cold antibodies indicates the possibility of mycoplasma or mononucleosis. Autoimmune hemolytic anemia with positive CUMs for warm antibodies indicates the possibility of cancer or autoimmune pathology. It is important to clarify that we can find spherocytes in autoimmune hemolytic anemia, differentiating the causative pathology through CUMs. In the case of autoimmune hemolytic anemia, there is the presence of spherocytes associated with positive CUMs, while in spherocytosis there is the presence of spherocytes associated with negative CUMs. Paroxystic nocturnal hemoglobinuria. It occurs secondary to alterations in the PIGA gene, which leads to alterations in membrane proteins, mainly in the ankyrin protein, leads the MAC complex to attack the membrane, causing cell lysis. Diagnosis can be made by flow cytometry, which shows clonal expansion of CD55 negatives, CD55. The treatment is supportive, but in severe cases equalizumab can be administered. Laboratory values according to normocytic anemia. Normocytic anemia due to hemorrhage, low hemoglobin, normal LDH, normal haptoglobin, normal bilirubin. Normocytic anemia due to hemolysis, low hemoglobin, elevated bilirubins, elevated LDH, low haptoglobin. Normocytic anemia due to leukemia, low hemoglobin, normal bilirubin, normal LDH, normal haptoglobin, altered peripheral blood smear and alterations in the bone marrow biopsy. Normocytic anemia due to chronic renal failure, normal bilirubin, low hemoglobin, and normal LDH. 10 rules in leukemia for the USMLE. 1. Origin oft and B lymphocytes is CD34. 2. T cells may be marked as CD3, CD4, CD8. 3. B cells are usually marked with CD20. 4. AUER rods are present in acute myeloid leukemia. 5. Red Stenberg are present in Hodgkin's lymphoma. 6. Acute myeloid leukemias are positive for myeloperoxidase. 7. Acute lymphoid leukemias are positive for TDT. 8. Acute leukemias are proliferations of immature forms. 9. Chronic leukemias are proliferations of mature forms. 10. Chronic leukemias are asymptomatic and acute leukemias are symptomatic. Acute myeloid leukemias, AML. AML presents as proliferations of immature forms that generate decrease in the levels of platelets, neutrophils, and lymphocytes. Patients present with symptoms of bleeding, fever, and infections. Cellularity is shown with immature and irregular cells, with a small nucleus and big amount of cytoplasm. You can find cell forms called hour rods. There are variants, type M3 or acute promyelocytic leukemia, APL, which present translocation 1517T, 1517, with alterations in retinoic acid receptors. Megakaryocyte acute myeloid leukemia is myeloperoxidase negative, but all other acute myeloid leukemias are myeloperoxidase positive. Acute lymphoid leukemia, all presents as proliferations of immature forms that generate decrease in the levels of platelets, neutrophils, and lymphocytes. Patients present with symptoms of bleeding, fever, and infections. Cellularity is shown with immature, irregular cells with a small nucleus and ample cytoplasm. It can be classified into B-cell acute lymphoid leukemia, B-all, and T-cell acute lymphoid leukemia, T-all. B-cell acute lymphoid leukemias are marked with CD10, CD19 or CD20, and T-cell acute lymphoid leukemias are marked with CD2, CD3, CD4, CD5, CD6, CD7 or CD8. This last type of leukemia can present translocations 9 to 22, Philadelphia chromosome, and translocations 12 to 21. In general, acute lymphoid leukemias are positive for TDT. Chronic myeloid leukemia, CML. CML presents as proliferations of mature forms that generate an increase in cellularity, without symptoms, and excessive proliferation of leukocytes, generally greater than 60,000, presents with translocation 9 to 22 in BCR/ABL fusion, Philadelphia chromosome, and elevation of tyrosine kinase receptors. Chronic lymphoid leukemia, CLL. CLL presents as proliferations of mature forms that generate an increase in cellularity. The patient presents without symptoms. There may be excessive proliferation of leukocytes. They are subclassified into B-cell chronic lymphoid leukemia and T-cell chronic lymphoid leukemia. B-cell chronic lymphoid leukemia is CD20 marked and forms blood hyperviscosity generating smudge cells. It can present with a variant called hairy leukemia. T-cell chronic lymphoid leukemia can generate lytic lesions and is marked with CD4. Treatment of leukemias is based on the classification of each one. Chronic myeloid leukemia treatment is made with imatinib, chronic lymphoid leukemia is treated with adenosine, acute promyelocytic leukemia could be with retinoic acid. It is important to identify age, since age is associated with certain types of leukemia. Acute myeloid leukemia and chronic lymphoid leukemia are more common in elderly patients, chronic myeloid leukemia is more common in adult patients, and in children is more frequent. Acute lymphoid leukemia. 7. Multiple myeloma. Multiple myeloma is generated secondary to altered proliferation of plasma cells due to incomplete or altered forms of immunoglobulin chains. These immunoglobulins initially come from matured and CD20 labeled B lymphocytes, plasma cells. Under normal conditions, plasma cells would generate immunoglobulins of 2 light chains and 2 heavy chains, but in cases of multiple myeloma, immunoglobulins of a single light chain are generated, leading to deposits of these light chains in the urine, producing the Bence-Jones protein and, in addition, stimulating the coin-shaped accumulation of red blood cells, generating the Rayleigh sign. It can be diagnosed with electrophoresis of proteins, where excessive peaks of immunoglobulin are noted, surpassing the peaks of albumin. Within the evaluation of a patient with bleeding, it is important to take into account the origin of the bleeding. The origin of the bleeding can be evidenced as alteration of primary hemostasis or as alteration of secondary hemostasis. Primary hemostasis is governed by platelets, whereas secondary hemostasis is governed by coagulation factors. Changes in primary hemostasis can be assessed through platelets and bleeding time BT. Secondary hemostasis alterations can be evaluated through the PT, PTT, and INR, since through these last laboratory tests we are evaluating the factors of the coagulation cascade. To understand the alterations in primary and secondary hemostasis, we must remember the normal physiology of coagulation. Platelet aggregation. In the event of trauma or inflammation, the von Willebrand factor, which is associated with factor VIII, is expressed in the endothelium, which generates platelet attraction, leading to expression in platelets of glycoprotein 1b. This 1b glycoprotein binds to von Willebrand factor. Subsequently, the platelet is activated through ADP and intracellular calcium, generating expression of glycoprotein 2b. This 2b glycoprotein binds to the 3a glycoprotein of another platelet through the intermediation of fibrinogen. This situation occurs exponentially, generating platelet aggregation, and thus the plug is generated at the site of the leak, due to trauma or inflammation. This process generates a weak plug or thrombus. Subsequently, the collagen that has been secondarily exposed to damage or inflammation generates activation of coagulation factor 12, and subsequently all the factors of the coagulation cascade are triggered. Activation of the coagulation cascade. It is initiated through collagen that has been exposed by tissue damage or inflammation, which activates factor 12, generating a chain activation until factor I, fibrinogen, is activated. This fibrinogen serves as an intermediate between glycoproteins 2b and 3 of each platelet to allow platelet aggregation. Factor I, fibrinogen, is converted to factor Ia, fibrin. This fibrin generates an interweaving of threads in the platelets, making platelet aggregation stronger and more adherent, leading to the formation of a strong clot. The body then stabilizes the formation of these clots through clot destruction. Clots destruction. Within the physiological process, activation of plasminogen to plasmin is generated through TPA. This activated plasmin generates clot rupture to maintain a stabilization between clot formation and prevent disseminated coagulation. This destruction of the clot via plasmin results in clot debris such as D-dimer, DD. Taking into account these processes of platelet aggregation, activation of the coagulation cascade, and destruction of clots, we can more easily understand the pathological processes that are involved in these three processes. Therefore, we can say that if we have bleeding due to alterations in primary hemostasis, we will find alterations in platelets either in their number or in their function, as well as alterations in bleeding time BT. If we find alterations in secondary hemostasis, we can find alterations in the PT, PTT, and INR levels. In the same way, if we find alterations in the destruction of clots, we will find altered values of dimer. Alterations of primary hemostasis. Hemolytic uremic syndrome HUS, it starts secondary to infection by E. coli 0157H7, consumption of raw or undercooked meat, which causes platelet sequestration, generating a decrease in circulating platelets and causing intraarterial plugs, which generates destruction of red blood cells when they attempt to pass through these plugs, which is represented in microangiopathic hemolytic anemia and the presence of schistocytes in the peripheral blood smear. Within the laboratory tests, we will find normal levels of fibrinogen, D-dimer, PT, and PTT, but low platelet levels. Thrombotic thrombocytopenic purpura TTP, the pathophysiological mechanism is identical to the hemolytic uremic syndrome HUS, the difference is the cause. In thrombotic thrombocytopenic purpura, the cause is factor ADAMS 13 deficiency. Under normal conditions, this factor breaks the continuous union between the von Willebrand factors. Since it is absent, there is no one to separate the von Willebrand factors, which generates continuous signaling for platelet aggregation, platelet sequestration, and a decrease in the amount of circulating platelets, leading to the formation of an intravascular plug that lyses red blood cells when they attempt to pass through these plugs. Patients with thrombotic thrombocytopenic purpura have normal fibrinogen, D-dimer, and PTT values, but low platelet levels associated with the presence of schistocytes in the peripheral blood smear and the presence of microangiopathic hemolytic anemia. Disseminated intravascular coagulation DIC is a combination of alteration of primary hemostasis and secondary hemostasis, generally after or secondary to a systemic septic state or inflammatory process. Platelet aggregation is continuously generated by the inflammatory process, generating a decrease in the platelet count, but at the same time the coagulation cascade is overactivated in an attempt to improve the thrombus that is caused by the platelet aggregation. This leads to the consumption of the factors of the coagulation cascade, generating elevation of the PT and the PPT. At the same time, in an attempt to produce stability, the clot destruction mechanism is activated, which leads to increased levels of D-dimer. Therefore, in these patients we will find low levels of fibrinogen, high levels of D-dimer, low levels of platelets and high levels of PT and PTT. Immune thrombocytopenia secondary to heparin. The typical clinical context is a patient receiving heparin treatment who subsequently presents with decreased platelet levels. This is generated because heparins induce antibodies against platelets. Immune thrombotic thrombocytopenia, presence of antibodies that destroy platelets. Alterations of secondary hemostasis. Unlike primary hemostasis, which presents with signs of superficial bleeding, gingival, vaginal bleeding, or petechiae, alterations in secondary hemostasis present with signs of deep bleeding, such as joint bleeding. In general, alterations in secondary hemostasis are associated with deficiencies of factors of the coagulation cascade. Von Willebrand factor deficiency. Von Willebrand factor deficiency is generally associated with decreases in factor VIII. Therefore, those patients are associated with low levels of factor VIII, combination of primary and secondary hemostasis disorders. These patients will show up with superficial bleeding, a drop in factor VIII, and an increase in PT, PTT, as well as an abnormal ristocetin test. Use of warfarin. Warfarin alters vitamin K depending factors 10, 9, 7, 2 protein C and S, therefore it can generate alterations in secondary hemostasis. Disseminated intravascular coagulation (DIC) affects both primary and secondary hemostasis. In the evaluation of patients with secondary hemostasis disorders, blood mixing studies are performed, where the patient's plasma is mixed with factors of the coagulation cascade, in an attempt to identify which factor is deficient. In these situations, there are two possibilities. If the patient improves after having mixed the serum with the factors of the coagulation cascade, it means that there is a deficiency of one of the factors of the coagulation cascade. If, on the contrary, there is no improvement, we are facing an immunological situation that is generating antibodies against one of the factors of the coagulation cascade. 1. 2. Thrombophilia. It is defined as the increase in the production of clots secondary to the following causes. Factor V mutation, Factor V Leiden, Factor 2 mutation, Protein C deficiency, antithrombin deficiency. Factors V and 2 are procoagulants, so their mutations increase the coagulation state, thrombophilia. Protein C and antithrombin are controllers of factors V and 2 respectively, anticoagulant mechanism, therefore their deficiencies lead to procoagulant states, thrombophilia. In general, thrombophilic states are treated with low molecular weight heparins in association with warfarin. 9. Hodgkin lymphoma. Presence of red Sternberg cells, owl's eye. Marking CD15, CD30. 10. Non-Hodgkin's lymphoma. Proliferation and alteration in the vast majority of B cells, 95%, which is why they are marked as CD20. B-cell non-Hodgkin lymphoma is subclassified into follicular type non-Hodgkin lymphoma, mantle non-Hodgkin lymphoma, marginal Malt type non-Hodgkin lymphoma, Burkitt type non-Hodgkin lymphoma, diffuse large B-cell lymphoma, non-Hodgkin lymphoma. 11. Aplastic anemia. Aplastic anemia is considered a destruction of the stem cells of the myeloid lineage. It generally occurs secondary to the effects of radiation, use of chloramphenicol, exposure to benzene, exposure to the Epstein-Barr virus, HIV, hepatitis, or Fanconi anemia. The bone marrow is in charge of producing both the myeloid line and the lymphoid line from the stimulation of stem cells, but due to the destruction of the stem cells due to the aforementioned causes, a drop in red blood cells, platelets, neutrophils, and leukocytes is generated, causing the state of pancytopenia. As a consequence of the fall in the levels of red blood cells, an overactivation is generated at the renal level in the production of erythropoietin, EPO, to try to compensate the state of anemia, which is why in aplastic anemia we find elevations in the levels of EPO. Due to the absence of production of the myeloid line, the bone marrow begins to generate a state of marrow atrophy, which leads to the marrow being occupied and infiltrated by fat, generating a state called dry bone marrow tap. Clinical presentation of patients with aplastic anemia, decreased red blood cell count, which is expressed in anemia, fatigue, and paleness. Decreased platelet count, which is clinically seen with bleeding, petechiae, and the appearance of purpura. Decreased leukocyte count, which can be expressed clinically with states of frequent or chronic infections. 12. Hemolytic anemia. Hemolytic anemia can be classified into two types, microangiopathic hemolytic anemia and macroangiopathy hemolytic anemia. Microangiopathic hemolytic anemia. The causes of this type of anemia can be caused by disseminated intravascular coagulation, DIC, hemolytic uremic syndrome, HUS, thrombotic thrombocytopenic purpura, TTP, chronic hypertension or hypertensive crisis. In this type of anemia, platelet sequestration is generated at the vascular level, which leads to lysis generated by the passage of red blood cells through these sequestration spaces, generating the presence of schistocytes and helmet cells. This happens in DIC, HUS, and TTP. In the case of chronic hypertension or stages of hypertensive crisis, due to vasoocclusion or arterial vasoconstriction in the small vessels, when the blood cells try to pass through this narrowing spaces, lysis of the red blood cells is generated. The main hematobiochemical pathologies are orotic aciduria and ornithine transcarbamylase deficiency, OTC deficiency. In order to have a better understanding of these pathologies, it is necessary to evaluate the synthesis of nucleic acids. The synthesis of pyrimidines begins from the union of glutamine with CO2 and ATP. The union of these three components through the catalyzation of the enzyme carbamoyl phosphate synthetase 2 CPS2 (CPSI) is in the urea cycle, achieves the carbamoyl phosphate composition. Subsequently, carbamoyl phosphate is transformed to orotic acid. Orotic acid is now converted to uridine monophosphate (UMP) via uridine monophosphate synthetase. Subsequently, uridine monophosphate (UMP) is transformed to uridine diphosphate (UDP), which in turn is converted to deoxyuridine diphosphate (DUDP) through ribonucleotide reductase. Ribonucleotide reductase can be blocked through hydroxyurea, which can be used in states of sickle cell anemia (SCA) in the desire to increase fetal hemoglobin levels. Subsequently, deoxyuridine diphosphate (DUDP) is converted to deoxyuridine monophosphate (DUMP), which in turn is transformed to deoxythymidylate monophosphate (DTMP) through thymidylate synthetase, thus generating finally the pyrimidines. Thymidylate synthetase requires tetrahydrofolate, THF, as a cofactor, and tetrahydrofolate, THF, in turn becomes dihydrofolate, DHF, and dihydrofolate, DHF, is converted to tetrahydrofolate, THF, through dihydrofolate reductase. Dihydrofolate reductase can be blocked by methotrexate or trimethoprim, while thymidylate synthetase can be blocked by 5-fluoroacyl. It is necessary to know perfectly the pyrimidine synthesis cycle to understand hematobiochemical pathologies. Orotic aciduria. There is an important point in the pyrimidine synthesis cycle where conversion to uridine monophosphate (UMP) is generated from orotic acid through the enzymatic catalyzation of uridine monophosphate synthetase (UMP synthetase). In the case of orotic aciduria, there is a deficiency of uridine monophosphate synthetase (UMP synthetase), leading to a deficiency in uridine monophosphate (UMP) levels and an increase in orotic acid levels. The continuous accumulation of orotic acid generates accumulation of this molecule in blood and urine and absence of continuity of the pyrimidine synthesis pathway, expressing the presence of megaloblastic anemia due to the low synthesis of pyrimidines. But it is important to highlight that unlike other pathologies that present with megaloblastic anemia, in the case of orotic aciduria there is no presence of hyperammonemia and there is no improvement to treatment with vitamin B12 and B9. Treatment of patients with orotic aciduria, it is targeted with uridine. OTC deficiency. From the mitochondria, specifically in the urea cycle, carbamoyl phosphate will be generated. This compound is also part of the pyrimidine synthesis pathway for nucleic acids. Carbamoyl phosphate binds to ornithine to generate citrulline in the urea cycle via ornithine transcarbamylase. When presenting with ornithine transcarbamylase deficiency, OTC deficiency, states of hyperammonemia are generated because urea cannot be eliminated due to alteration of the urea cycle. At the same time, because nitrogenous elimination compounds are not formed in urine, BUN levels decrease and elevations in carbamoyl phosphate levels can be observed. Ornithine transcarbamylase (OTC) deficiency is considered an X-linked recessive disease in which women are often carriers and men are sick. Treatment of patients with ornithine transcarbamylase (OTC) deficiency focuses on reducing blood nitrogen levels based on low-protein diets. It is important to make a comparison between vitamin B12 and B9 deficiency, pernicious anemia, uric aciduria, and ornithine transcarbamylase (OTC) deficiency. Vitamin B12 deficiency presents with megaloblastic anemia, improves with the administration of vitamin B12, there is no hyperammonemia and may be associated with neurological symptoms. Vitamin B9 deficiency presents with megaloblastic anemia, improves on administration of vitamin B9, there is no hyperammonemia, and it is not associated with neurological symptoms. Pernicious anemia, it presents with megaloblastic anemia, it does not improve with the oral administration of vitamin B12 or vitamin B9, its origin is autoimmune, hyperammonemia states are not observed. Uric aciduria, it presents with megaloblastic anemia, it does not improve the administration of vitamin B9 or B12, it shows with hyperammonemia, there is elevation in uric acid levels and its treatment is uridine. Ornithine transcarbamylase (OTC) deficiency does not present with megaloblastic anemia, does not improve upon administration of vitamin B9 or B12, presents with states of hyperammonemia and elevated carbamoyl phosphate, and treatment focuses on reducing nitrogen intake, low-protein diets.